Okay, let's dive right in. Welcome to today's explainer. We're putting on our medical detective hats to solve a very painful and honestly very common mystery. You know the one, that burning, gnawing ache in the upper stomach that literally wakes people up in the middle of the night? We're investigating peptic ulcer disease. It's actually one of the most common gastrointestinal disorders globally, and yet it is surrounded by just a ton of misinformation. So get ready, because we're going to crack this case wide open. First things first, let's address the elephant in the room. For decades, if you had stomach pain, people told you to stop eating spicy foods and to calm down because your emotional anxiety at work was giving you an ulcer. Well, guess what? That is a total myth. Absolutely not true. As you're going to see, the real culprits are hiding right in plain sight, and they actually have zero to do with your hot sauce habit or your stressful commute.
So, to really get this, we have to understand what we're actually dealing with. Peptic ulcer disease, or PUD, is essentially a structural failure. Think of it kind of like a crime scene inside your body. It happens when open sores, which are the ulcers, develop directly in the lining of your stomach or sometimes just below it in that first part of the small intestine, which doctors call the duodenum. Basically, these sores are the direct result of damage from your own stomach acid and digestive enzymes just eating away at vulnerable tissue.
So here is the roadmap for our clinical investigation today. We'll start with the anatomy of an ulcer, then look at the main culprits, followed by symptoms and danger signs. After that, diagnosis and treatment, and we'll wrap up with recovery and prevention.
Okay, let's get right into part 1, anatomy of an ulcer. I want you to think of the normal, healthy state of your stomach as this epic battle between a shield and a sword. Your stomach is quite literally a vat of highly corrosive acid and protein-digesting enzymes called pepsin. That's the sword. It needs those, right, to break down your food. So why on earth doesn't it digest itself? Well, because of the shield. Your body has these incredible protective mechanisms. We're talking a thick mucus layer, bicarbonate secretion to neutralize the acid, a really rich blood supply for cell regeneration, and specialized lipids called prostaglandins that maintain this whole defense system. Under normal conditions, it's a perfectly delicate balance.
But with peptic ulcer disease, that balance totally fails. Let's walk through the microscopic pathology here. Step 1, the protective mucosal lining gets damaged. The shield basically drops. Step 2, without that barrier, the sword attacks. Corrosive acid and pepsin penetrate right into the deeper, highly vulnerable tissues of the stomach wall. Step 3, this localized destruction forms an open sore. That's the ulcer itself. And finally, step 4, because your stomach is constantly churning with acid, this continued injury causes chronic inflammation, and that severely delays the body's natural healing process.
Moving on to part 2, the main culprits.
So, if emotional stress and spicy food aren't the things dropping the shield, well, what is? Despite all the rumors and old wives' tales you might have heard, the medical data is incredibly clear on this. Globally, there are really only 2 leading root causes for this disease, just 2 primary suspects that we need to investigate.
And these suspects operate with very distinct mechanisms. Suspect number 1 is a bacteria called Helicobacter pylori, or H. pylori. This bacteria literally colonizes your stomach. It directly damages that protective mucosal layer and causes chronic inflammation. Suspect number 2, well, it might be sitting in your medicine cabinet right now. NSAIDs, or non-steroidal anti-inflammatory drugs. This includes long-term use of everyday painkillers, things like ibuprofen, naproxen, diclofenac, and aspirin. How do they cause ulcers? Well, they chemically reduce your body's production of those protective prostaglandins we mentioned earlier. It effectively just turns off your stomach's defense system. Now, while H. pylori and NSAIDs are definitely the ringleaders, there are some secondary risk factors that can make things worse. Smoking and heavy alcohol consumption severely irritate the stomach lining, and they delay healing. Older age and family history also play a role. And hey, notice stress is actually on this list, but we have to be super precise here. In a medical context, this means severe physiological stress to the physical body. We're talking major trauma, severe burns, or being critically ill in the ICU. Not, having a bad day at the office. Finally, there are very rare conditions like Zollinger-Ellison syndrome, which can cause massive acid overproduction.
All right, part 3, symptoms and danger signs.
The most common symptom overall is a burning upper abdominal pain, which is often accompanied by indigestion, bloating, or nausea. But get this, the exact timing of the pain is actually a brilliant clue to where the ulcer is located. It's a classic medical comparison. If it's a gastric ulcer, meaning it's located directly in the stomach, the pain typically worsens shortly after eating. That often leads to a loss of appetite and weight loss. But if it's a duodenal ulcer, which is actually more common overall, the pain often improves temporarily when you eat because the food kind of buffers the acid, but then the pain comes roaring back a few hours later, frequently waking patients up in the dead of night.
Now, I want to be incredibly clear about these next warning signs, because these are absolute, life-threatening medical emergencies. If a patient experiences vomiting blood, which is called hematemesis, or black tarry stools, known as melena, they need urgent care right away. The exact same goes for sudden, severe abdominal pain, fainting, dizziness, or any signs of shock, like a rapid heart rate and low blood pressure. These symptoms mean the ulcer has escalated from just a painful sore to a critical internal crisis.
Those emergency signs point to some really severe physical complications. If left untreated, the acid can erode right through a major blood vessel, causing severe gastrointestinal bleeding. The ulcer can even penetrate deep into adjacent organs, or, worst of all, it can entirely perforate the stomach wall. That leaks stomach contents right into the abdominal cavity, causing a deadly infection called peritonitis. Plus, chronic gastric ulcers sometimes carry an increased risk of gastric cancer. That's exactly why doctors will often mandate biopsies just to totally rule out malignancy.
Section 4. Diagnosis and treatment.
So, how does the medical team actually solve this problem? Well, it starts with a really thorough medical history and physical exam, maybe some blood work to check for anemia, but step 2 is the true gold standard, the upper GI endoscopy, or gastroscopy. A doctor actually uses a tiny camera to directly visualize the internal crime scene, locate the ulcer, and check for any bleeding. While they're in there, step 3 is taking a biopsy if it's needed. And finally, step 4 is absolutely crucial, specific testing for H. pylori. This can be done via urea breath tests, stool antigen tests, or biopsies, just to see if that bacterial culprit is hanging around.
To disarm the sword so the shield can rebuild, doctors use a very specific medical arsenal. The heavy hitters here are proton pump inhibitors, or PPIs, like omeprazole and pantoprazole. These aggressively reduce acid production in the stomach, which gives the tissue the perfect environment to heal. We also use H2 receptor blockers like famotidine to reduce acid. And look, while over-the-counter antacids are great for temporary symptom relief, they don't actually heal the ulcer on their own. We really have to shut down the acid at the source.
But if our tests show that H. pylori bacteria is the culprit, just lowering the acid isn't going to be enough. The ulcer will just come back. We have to completely eradicate the bacteria. This involves a really specific combination therapy. Step 1, attacking the bacteria with multiple targeted antibiotics simultaneously. Step 2, adding a PPI to heal the lining. Step 3 is pretty fascinating. Doctors actually have to adjust the specific antibiotics they use based on local antibiotic resistance patterns in your specific geographic area. The ultimate goal in step 4 is the total eradication of H. pylori to prevent the ulcer from ever returning.
And our final section, Part 5, Recovery and Prevention.
First off, just a quick point of clarification here. Patients often confuse peptic ulcer disease with GERD, or acid reflux. Remember, PUD is a structural issue. We're talking open sores in the lining causing deep, burning abdominal pain. GERD is a functional issue where acid flows backward up into the esophagus, and that causes the classic feeling of heartburn higher up in the chest. Knowing the difference really helps ensure you're following the right recovery plan.
Now, in those severe emergency cases we talked about earlier, like perforations or uncontrolled bleeding, surgery is absolutely required. And what's really interesting here is the role of post-operative rehabilitation. While physiotherapy obviously doesn't cure an ulcer, it is incredibly vital after major abdominal surgery. Physiotherapists guide patients through deep breathing exercises and incentive spirometry to prevent post-op lung complications. They also establish walking programs and gentle mobility routines to get your physical endurance safely restored. For the vast majority of people recovering without surgery, prevention really just comes down to actionable lifestyle choices. Eat balanced meals with whole grains and lean proteins. Stop smoking and limit alcohol. You've got to let that mucosal lining breathe and heal. Be incredibly careful with unnecessary NSAID painkillers too. Definitely talk to your doctor about alternatives if you need them. And while spicy food doesn't directly cause ulcers, if you find that extremely spicy meals, large fatty dinners, or excess caffeine trigger your specific symptoms, listen to your body and limit them. This brings us to a wonderfully optimistic conclusion straight from current clinical guidelines. Early diagnosis, proper medical treatment, eradication of H. pylori, and healthy lifestyle choices can heal most ulcers, prevent life-threatening complications, and restore long-term digestive health. Peptic ulcer disease is incredibly painful, yes, but with modern medicine, it is highly, highly treatable. You really don't have to suffer in silence.
Which leaves us with this final thought. Think back to the beginning of our explainer today. How many people out there are just chugging antacids, blaming their high-pressure jobs for their stomach pain, when the reality is entirely different? Could your recurring stress stomachache actually be a structural ulcer caused by NSAIDs, or a highly treatable H. pylori infection? If the symptoms we discussed today sounded a little too familiar, well, it might be time to stop blaming the hot sauce and go get some evidence-based medical clarity. Thanks for joining me on the Explainer today, and stay curious.